Assalamu alaikum. Good afternoon from Malaysia. Thank you very much for joining this 37th webinar of MedEd web series. Is the screen visible?
Yes, it is.
Yes.
All right. Thank you very much. Now, today's topic, as you know, is communication skills in medical practice. And our speaker is Professor Dr. Rukhsana Hussain Malik. So I will just invite her to take over this session. You can always ask questions even during the presentation if you feel like, or we can take questions towards the end as well. Right, now over to Dr. Rukhsana Hussain Malik.
ठीक है जल्दी से
Assalamu alaikum and welcome to everyone to this webinar on the communication skills in medical practice, what, why, how, and when. The learning outcomes of this webinar, I'm sure all of you have read, is that we should be able to explain the principles underpinning the concept and rationale of communication in medical practice, which is a very important component of clinical examination of the patient and working in the clinician and working with the multidisciplinary people. Identify the various types of communication and explain the communication process, practically how the communication occurs. Explain the guidelines of regulatory bodies for teaching of communication skills to undergraduate medical students. Discuss different models and methods used for teaching and learning communication skill. Teach communication skill effectively in accordance with established guidelines. And at the end of the day, evaluate the communication skills of the students using reliable and the valid assessment methods. So we start with the communication, the what part of it. In this part, we are going to cover what is communication, what are the elements of communication, and what are the communication theories. We are not going to go into a greater detail of it, but we are going to touch over this process so that we know exactly how the communication occurs. The communication, this is an active process of exchanging information, ideas, thoughts, or feelings between individuals or the groups through various mediums. They can be the verbal, written, signal, or behavior to achieve understanding and mutual comprehension. For example, when we say WhatsApp is an effective medium of communication, then we are talking about the medium of communication, which is WhatsApp. I'm sure she will succeed in examination is your feeling. That is how we feel, that we are sure that somebody is going to pass an examination. So we can convey this feeling as well through communication. Transmission of information is much quicker by phone than sending letters. These are the different ways in which the information can be spread and information can be gathered. Communication involves both understanding and expression. If you don't understand the meaning of the statement, then you wouldn't know what the communication is all about. For example, I have written a sentence below that, exactly below this sentence. We cannot understand this sentence unless we know which language it is in. So actually it is the same. Communication involves both understanding and that expression, but there are many ways, different ways of writing these sentences, and this is one of them. So until and unless we know that, we don't know. So what I'm trying to say over here is that we have to understand the language and we had to understand how that language is expressed. The key types of communications are verbal, which is face-to-face oral communication. It can be visual, in which images, pictures, graph, videotapes, and expressions they are shared, and we can gauge what the person's mood is, what the expression is by looking at those pictures. The written is through the letters, notes, mails, emails, WhatsApp. It's a huge way of communication nowadays in which we can do the verbal and the written sort of communication. There is virtual communication as well, which is growing very fast because of technology. When the peoples are not in the same place, it includes video calls, email, text messages, and social media, and many, many more of them. So what is the communication theory? Communication theory says that communication is the process by which meaning is assigned and conveyed. It is not the signals which we are concerned about, it is the meaning of those signals which is of importance. So it's a process by which meaning is assigned and conveyed in an attempt to create shared understanding. Communication theory is the study of how information is exchanged between individuals, groups, or organizations. It encompasses the sender and the receiver. Sender is the person who starts the conversation, who sends the conversation, and what the message is sent is encoded. And the receiver is the person who receives the message, and he or she will decode that message to understand it. So the sender message is encoded, which will be decoded by the receiver when the receiver receives that message, and that occurs automatically through the process of the lines. The message or the signal is actually the content of information that is being communicated. The medium or the channel is the method through which the message is transmitted, example, through the books, television, or electronic media, or the internet like we are doing just now. The feedback is the response from the receiver back to the sender, indicating whether the message was understood. And the noises practically are any interference that affect the clarity or accuracy of those messages. Example, the physical noises, like when we are talking, there are some extra sounds which you can hear, the machinery which is working somewhere over there, or the baby is crying in the other room, or there are some other ways that like the rain is coming. So all these are the physical noises which can interfere in the conveying of the message. There can be the language barriers in which you don't understand the language in which the person is talking. So that creates a noise, and can be continuous, which is always there. It is an intermittent sound. For example, in the room, the fan is moving, and the movement of the fan creates a sound, and that sound will be continuously heard until and unless you switch off that fan. Or it can be intermittent, which can come and go. For example, there is a thunder outside, and that thunder will come and then it will go. And if the rain is persisting, it will keep on coming and going. So that will be intermittent. It can be impulsive. It comes suddenly. For example, I get a cough and I start coughing. That will be an impulsive sort of a noise. Or low frequency noises, which are in the surrounding all the time and which can be heard by the people. Communication theories which are important for the medical students includes Bandura social cognitive theory, which says that the learning communication skill by observing and imitating the experienced practitioners and practicing these in simulated environment. How do we learn? Is by listening and observing the other people who are around us. We try to imitate how they are doing their communication, and then we practice them in the simulated environment, and then we try to mimic those people in a good way, that we want to be like them. This is done by observation. Students observe the experienced doctors during patient interaction to see effective communication techniques in action. For example, many of the students learn how the professor conducts the ward round. And in that method, he or she will learn how the professor or the doctor, whom they like, will communicate with the patients or the attendants around them, and they try to mimic that. Or by the modeling, clinical instructors and mentors demonstrate ideal communication behavior and skills, serving as role models for the students to emulate. By practice, students engage in role-playing exercises and simulated patient interaction to practice their communication skills. This can be done not only with the human beings in a simulated environment, but also, for example, it has been taught that how when you go to the clinical skill labs and you communicate with the dummies over there, how you say hello and how are you and all those expressions with those mannequins. The feedback after practice sessions, students receive constructive feedback from instructors and peers, which help them to improve in their communication. And by reflection, students reflect on their own communication experiences, identify their strengths and area for improvement. Most of the students will practice that while watching the process which is going on in front of them, or even they talk to themselves while in the bathroom, and they will talk to the mirrors over there, and they will learn how to improve their communication. There is also another theory which is called as the transactional theory. Communication is a dynamic, continuous process which involves both sender and receivers, with feedback and adaptability being the key factors of this type of communication. So what happens is that there is two-way communication. Both doctors and patient actively participate and exchange information and respond to each other in conversation. This is one component of it. It is always two-way. Not doctor. If the doctor is all the time talking and doesn't get any response from the patient, practically he or she wouldn't know whether the information which he is giving has been transmitted to the patient or not. The feedback is doctor watch and listen to patients' responses and adjust their communication to make sure the patient concerns are addressed in real time. So if the patient is asking you a question and the question is being neglected by the practicing clinician over there, the patient will not be satisfied, because he or she will think that you are negligent of communicating to him or her, and the communication will be going on only in the one-way method. The context, the doctor considers the patient's environment, culture, and situational background to tailor the communication better. For example, if the patient is coming from a rural area, then your way of communicating to that person will be different from the person who is educated or who is from the urban area, or who are well aware of all the technologies and they know how to communicate in that context. So the level of the education, the level of the exposure of the people, the cultural background of the people, the communication skills of the people, they all matter in understanding the context of the communication. Then simultaneity, both doctors and patients send and receive messages simultaneously. Sometimes we don't think about it, that how we are sending the message. When we are angry, our facial expression will show over there. When we are happy, then the facial expression will be visible to the other people. So that is how the communication is being gauged by the receiver. What is the mood of the person he or she is talking to. And adaptability is the doctor change their communication styles based on the patient's reactions and the conversation flow. Sometimes you have to talk very slow to the patient. Sometimes we have to talk in their language. Sometimes we have to go step by step, telling them and repeating the same thing which we are telling them, so that they can understand the things better. So these are all the methods which are used in the transactional theory. Then is the narrative medicine, where we use storytelling or narration to improve the understanding and empathy while appreciating the patient's perspective. For that, there are training programs, train healthcare providers to elicit and interpret patient stories to understand their perspective. For example, patient comes to you, and if you ask the patient, how are you today? And the patient will start the story from somewhere else, and then he comes to that point. You have to be very patient to listen to that patient, because that is his way of narrating that what are his moods and how he or she have gone through the process of coming to see you. Reflective writing is another way of narration in which you can write your experiences to process emotions and develop empathy. Patient narratives listen to patient stories to understand their culture, their value, their beliefs, life, and the illnesses. Many a times it happens that a good amount of time is required to get to the point what the patient has come from before the patient have told you the detailed story of which is irrelevant, but which is very important for the patient to narrate. Interdisciplinary collaboration, work with professionals from different fields to better understand patient stories. The stories are interpreted in the different ways by the doctors, then by the, for example, nurses. Nurses will perceive it in a different way. If they are going to the physiotherapist, they are going to talk to the patient in a different way. So there are different ways of communication which we adopt to take care of the patient in the hospitals according to our own specialties. Case discussion is another way. Use patient stories in discussion to highlight the human side of medical care in deeper understanding. Empathy and compassion focuses on understanding the patient's story, not just their symptoms. It is very important that we don't rush through the history taking process, because sometimes in rushing that process and we giving the asking them the close-ended questions practically fail to elicit a lot of information which the students can tell, which can be helpful in the management of the patient. Then is the motivational interviewing method to engage patients with chronic health problems to explore and resolve uncertainty about behavior changes. The patients who are chronically ill have been growing through that communication process over the time. They have a different way. They have the different sort of emotions about the treatment and all those methods. And they need a different type of a listening ear so that they can convey their messages to the doctors properly. For that, you have to build the rapport, to establish a connection with the patient, to create a trusting environment in which the patient can tell you all the inner feelings which he or she is going through. You will ask the open-ended questions, encourage patient to talk about their motivations and goals. Active listening, recognize patient's perspective and the concern. Somewhere in the talk, they will share with you their feelings or their fears about the disease and the end product of that disease. Affirmation recognize and affirms the patient's strength and efforts. And reflective listening, reflect back what the patient says to show understanding and empathy. These are the ways in which we call them the OARS. The short form of it is OARS, OAARS, OARS. Summarize. It's very important that at the end of the storytelling by the patient, we should summarize to ensure that we have understood everything what the patient was saying, and we have agreed on the steps which we are going to take later on about the management of the patient. Eliciting change talk, encourage patients to express their reasons for change and their plans to achieve it. And collaborative goal setting, work together with the patient to set achievable and significant goals. Unfortunately, in the busy OPDs, we rush through all these processes, and sometimes we do miss a lot of important information which the patients will be giving us about their disease, about their worries, about their concerns, about their other issues which are either stopping them from taking for example, taking the medication or going through the process of recovery and all that thing. Patient-centered care is a new thing nowadays, in which the focus is on the health needs, the desired health outcomes, preferences, and values, with active patients' participation in their own care and decision-making. So practically, you cannot tell the patient that this is all what you can do about it. You have to listen to the story, and you have to bring yourself at the level of the patient and understand what the patient is going through and what sort of care they are asking for. Healthcare systems, it is the healthcare system's mission, vision, and the leadership which should be involved in the quality improvement and aligned to the patient desired central goals. Care is collaborative, coordinated, and accessible, with the right care being provided at the right time and the right place. Again, sometimes the patients are ambulatory and they want to have it being taken care of at the other places. So some arrangements have to be made to fulfill their desires. Care focuses on physical comfort, not only the physical comfort, but also the emotional well-being of the patient. That is very, very important component. Patient and family preferences, values, cultural traditions, and socio-economic conditions are also respected. And and the doctors will learn how to cater to the requirement of these issues to the best of their capabilities and with the best of their resources. Patients and their families are an expected part of the care and play a role in the decisions of the patient and at the patient and the system levels. So we are not only talking about the patients, we are talking about their families, the people who are concerned about them, and we cannot shun them out from the treatment procedures because they are part and parcel of that the whole environment, and they should be on board in knowing what the decisions have been made about the patient and to which level. Again, there will be the consent of the patient involved over there, who to tell the information, who not to tell, but still it is a game in which number of peoples they will be involved. The pressure of family members in the care setting is encouraged and facilitated. Information is shared fully and in a timely manner, so that patient and their family members can make informed decisions. We are not supposed to hide any information from the patients and the caretakers. They should know exactly what the situation is. That will burden either their financial situations, or that can be worrisome for them regarding the after effects of that disease. All these things should be shared with the patients and their families, so that they can make the informed decision. The communication skills, why then we need to know and have a good communication skills. Probably because as a student, there is a criteria set by the regulation bodies of different countries, and we have to follow that. Because when the students will become the doctors, the students should be well versed with the criteria of the regulation bodies, at least for the countries in which they are working. But generally, they should be more informed about the situation in other countries, so that they can improvise and improve the criteria or the level of the care in their own countries, and they can influence the regulation bodies in this respect. Good communication skills are an essential component of physicians' training. Effective doctor-patient communication leads to better compliance, better health outcomes, and the decreased litigation and higher satisfaction both for doctors and patients. So technically, it is a win-win situation for both. If we are good in communication and we are able to satisfy the patient, then it will decrease our responsibility and some litigations or the legal processes that can be avoided in this manner. Effective communications win the doctors the confidence and compliance of patients and help build a healthy doctor-patient relationship. These are the famous sayings of the people which have been quoted from different articles and journals. So effective communication wins the doctor the confidence and compliance of patients. If you are good in communication, no matter how sick the patient is, probably he will have a soft heart towards you and he will appreciate your effort, and that will help to build a healthy doctor-patient relationship. Ensure that students not only imbibe the nuances of the communication and interpersonal skills, but adhere to them throughout their career. This is very, very important, that what the students are doing in front of you, in front of your eyes, in the wards, throughout the 5 years of the teaching learning process, have they really imbued in them? Have they really make them the part and parcel of their life? It is very important, because if they don't adhere with those teachings or those methods, they are going to suffer in their careers, because later on they are going to end up in problems. So we have to not only teach them, we have to make sure that they learn them and they are steadfast in these learnings later on as well. The increasing demand for medical students to be trained to communicate effectively has seen the emergence of interpersonal communication skill as a core graduate competencies in medical training around the world. So practically, it is not only that you are talking about the doctor-patient over here, you are talking about the whole lot of the relatives on one side and the community at large. So practically, you know that if you have been misbehaving, for example, a doctor has misbehaved a patient, that news is going to spread into the community very, very quickly. So that will bring the bad name to that doctor. And similarly, if the doctor has been very nice and polite and patient with the patient, then patients are going to tell the good part of that person, and he will be more approached by the patients, especially those patients who have chronic illnesses and they are really in agony. Okay. Which are the regulation bodies? I start with the American Association of Medical Colleges, AME. Core competencies for medical students to help them communicate effectively, patient and other professionals. The AMC has come up with the 15 core competencies. Of those 15 core competencies, if you see in this picture, there are 4 competencies which are related to the communication. It is the social skills, it is the oral communication, it is the cultural competence, and it is the written communication. So all these are concerned with communication, and it forms almost 1/5 of all the competencies which are required in the doctor. Oral communication, be clear and concise, provide information in the way that is easy to understand. Don't use medical jargons, which is a very common thing, because we are more accustomed to of the medical jargons, but for them, for the patients, these are very new or very different sort of a language, so they won't be able to understand. So even if you keep on telling them about those conditions or those things, they will not understand them until unless you simplify it for them. To be active listener, understand the gist and the intent of what others says. It is very important to know. Adjust your approach to recognize and address the communication barriers which can be there. Social skills, be aware, consider the needs, goals, and feelings of the others. Be respectful, treat with respect, and adjust behavior in response to their cues. Be enthusiastic, create a positive vibe. So even the patient, if the patients are very, very sick, it is the mood and the face and the way of communication of the doctor which practically takes away a part of their disease or their illness or their pain. Not literally take away, but they can cheer up the patient because of that. Cultural competence, be aware of the diversity, understand the socio-cultural factors affecting interaction and the behavior of the patient. Be respectful of diversity, appreciate the multiple dimensions of diversity in the community. Be aware of the bias, recognize and address the biases in yourself and in others. Sometimes we are against some community, we are against some people, we are against some culture, and we are not supposed to show these biases when we are acting as the doctors. Like they say that you have to treat even the person who is your worst enemy. You can kill that person later on somewhere outside by shooting that person, but as a doctor, you have to be very, very involved in the treatment of that and do your best for the life of that person. The Journal Medical Council of the UK, it says that the medical professionals to have good communication skills with patients, their families, and colleagues. So it is a combination of the patient, their families, and the colleagues which are involved in the management of that patient. So the nurses, the ward staff, the other specialties which will be involved in the management of that patient, all will be included in that. So be clear, use simple language and avoid medical jargons. These will be a repetition because generally most of them are the same except for the variance of one or two in each council. Be respectful, give patient the same time and respect you would give to adults, and make sure that you give the same time and respect without any bias between the rich and the poor patients, because it is the severity of the illness which matters to you to first attend to which patient, then they're being the rich or the poor ones. Be compassionate, be considerate and sensitive in supporting patients' families. Be an active listener, give your full attention to what others are saying and understand their concerns. Be honest, be open and truthful, patient and their families. Previously, the doctors used to hide the bad things from the patients or their families, which sometimes have ended in disasters, and later on that has led to the legal processes. So the best thing will be that you should be open and truthful about the patient, his condition or her condition, and the consequences both with the patients and the families. For that, you need a very, very good communication skills. The medical students will start learning those skills in the medical life, but throughout their life, they have to do it to improve on these, and they will improvise on it as they go through the different experiences. Be responsive, response to patients' concerns and preferences. Be considerate of confidentiality, follow the GMC's guidance on handling the patient information. Be thorough, keep accurate records for continuity of care. Again, it is very important that the records kept by the doctors and the hospitals are very accurate, because again of the legal procedures that can ensure if there is some mismanagement is done. Seek the feedback, reflect on the feedback to improve your clinical skills, communication skills. Okay, the CANMATS has key competencies of the has 1, 2, 3, 4, 5, 6, 7, 8 different sort of competencies, and of those competencies, the competency as a communicator is again a very, very important one. Establish professional therapeutic relationship with patient and their families. So you are not going to go too personal with them, but you have to know their family background and the conditions in the family, for example, and their socioeconomic status, how much they can afford, and all those things you have to be aware of to treat the patient properly. Elicit and synthesize accurate and relevant information, incorporating the perspective of patient and their families. Share healthcare information and plans with the patient and the families. If you are changing the medication, if you are introducing something new in the care of the patient should be informed, and his or her consent should be there. His willingness to be the part of that that change should be ensured. Engage patient and their families in developing plans that reflect the patient's healthcare needs and goals. Document and share written and electronic information about the medical encounter to optimize clinical decision-making, patient safety, confidentiality, and privacy. So we cannot discuss one patient with another patient, one patient with the family of another patient in the ward. Generally see, for example, one patient in bed A is very sick and the bed 2 people, they want to know more about it. So you are not supposed to, the students should be taught not to communicate all that information to them, because each individual is different, and his or her confidentiality, the condition should be kept with yourself. The Malaysian Medical Council, MMC, says that the medical graduate should communicate clearly, sensitively, and considerately with patients, relatives, and other health professionals. So they have practically satisfied have mentioned the other health professionals in their opening statement. They should also be able to present patient case histories and clinical details in the concise and the sensitive manner. This is for the medical students. So the history taking should be concise and should be written in a sensitive manner. Be patient and compassionate. Avoid making patients feel rushed or busy. You should not look that you are in a hurry and you just will listen to the patient for his 1 or 2 sentences and then make the decisions. It is not logical, and it really is not helpful for the patients and the families. Be a good listener, clarify patients' expectations, and help them understand the treatment plan. You have to tell them that what are you going to treat them with, and what are the benefits and the side effects of that treatment plan. Be kind and courteous. Avoid being stern or businesslike. Be friendly and amicable. Build trust with patients by being gentle and asking casual questions. Be firm but pleasant. Avoid patronizing the patients or developing personal relationship with them. It is very, very important. And it is a big no-no with all the medical councils, but Malaysian Medical Council has specifically put it in the document because of different races over here and different level of the patients they will be seeing. Be attentive, acknowledge patients, and make sure that they are informed. Be sensitive, consider patient needs and wishes when presenting their case histories. Okay, I've put over there RUMC, which is the medical complex, a medical campus of RCSI and UCD. RCSI is the Royal College of Surgeons in Ireland, and UCD is the Royal College of Dublin. So these two institutes have come up with a campus in Malaysia, which is called as RUMC, and it's a private wing. It's a private so practically how the private people are tackling with the patients in Malaysia, bringing in their curriculum, which is catered to the need of the people in Malaysia. So it is a mixture and amalgam of two different cultures and different way. They are bringing in different ways. So practically, they want the effective communication involves active listening, empathetic understanding, and clear and concise expression of medical knowledge. Establishing strong patient-doctor relationship is built on the foundation of open, empathetic, and effective communication. Development of communication skills ensure that future healthcare professionals can establish the rapport, gain the trust, and deliver quality care. And healthcare professionals must navigate difficult conversations, deliver challenging news, manage patients' expectation with sensitivity and clarity. So they have come up only with the three main outcomes, but it practically encompasses everything which is to be done with the patient while they are in their care. The communication skills of how, okay, before I start with the how, in the previous one, I couldn't get the rules, the Pakistan Medical Council's database on that, how to tackle with the patients. So because it's very important, and neither of the Indian people, because from India, because a lot of our listeners, participants in this webinar from these countries, but unfortunately I couldn't get their documents. Okay, the communication skills, how? The verbal communication, the non-verbal communication, the written communication, professionalism in interpersonal communication, and elements of communication. We are going to tackle with these 5 headings in this one, in this component. Verbal communication. Clarity and precision, clearly explain medical condition, the treatment and procedures to patient and their families. The language used should be simple and clear with patient, which the patient can understand, avoiding medical jargons, especially in the countries in which the English is not the mostly understood language. For example, in Pakistan, many of the patients will not be able to understand English. Or, for example, in Bangladesh, they will be having similar problems. Or in countries where English is not being promoted as such. So it's better to communicate with the patients in their language than to be talking in English, which as a doctor, normally we communicate with each other in English. Structured information, present information in an organized manner, highlighting the most critical points first. It is very important that the main condition of the patient is not lost in discussion. It is very important that the most important findings in the clinical examination should be tackled first. Active listening, pay full attention to what patient and the family members and colleagues are saying. Take time to understand the point being made and ask questions as appropriate. Full attention, don't interrupt while other is speaking. Normally, when the doctors are in a hurry, they tend to skip that part and just listen part of the sentence, and then they go on to the next point with the patient, which is a bad example for the students which are with the senior doctors at that time, and for the patients as well, because they want the doctors to listen to them carefully. So please, we should make sure that the students spend time with the patient and understand their concerns, which might not be relevant, but which will give some satisfaction to the patients. Don't interrupt while others is speaking. Reflective listening, repeat back what the patient says to confirm the understanding. For example, so you were saying that means that you repeat that sentence what the patient was saying to reconfirm that what you have understood is right. Questioning skills, the open-ended questions encourage patients to share and confirm information. Example, can you tell me about your pain? If the patient says he's having pain, so can you tell me more about your pain? The closed-ended question will be use specific questions for precise information. Example, was the pain sharp or dull? So you're practically putting that question directly to the patient. Sometimes the close-ended questions are needed and are allowed, but usually the most of the conversation should be open-ended so that you can get the real information from the patients. Explanation of medical jargon, simplify, break down complex medical terms into simple, understandable perceptions, and summarize, ensure that the patient understand their condition and the treatment. Adaptability, cultural sensitivity is very important. Again, it is coming. Be careful of the cultural difference and adapt communication accordingly. Some methods of treatment, for example, are not acceptable in some cultures. Some method of talking to the patient are not acceptable in some cultures. The way you talk with the patient, you sit with the patient, you communicate with the patient again, has a very lasting effect on the patient's understanding of the doctor and how and the students. So it is very important that we should be aware of the culture in which we are working or in which we are teaching the students, so that they are mindful of it. Adjusting to the patient's need, modify the communication style based on the patient's emotional state and the level of understanding. Interpersonal skills very important to build a understanding and with the patient, establish a connection with patients through small talk and genuine interest in their well-being. Confidence, communicate confidentiality to install trust and credibility. Non-verbal communication, mastering non-verbal communication skills complement verbal communication, leading to better patient outcomes, higher patient satisfaction, and more effective teamwork. Proximity, the personal space between the patient and the doctor, the way they sit, for example, if they are in the clinic, the distance between the patient and the doctor, this all matters, and we have to be very, very careful about seating arrangement of the patient and their attendees who are accompanying them in the clinic. So maintain appropriate distance for comfort, adjusting the distance, move closer or further away based on the patient's comfort level and the context of the conversation. Body language, appropriate eye contact shows the attentiveness and builds trust. Facial expressions convey empathy, concern, and understanding. So your face should be very, very talking, so that the patient can understand that whether you are understanding what he or she is saying. Your expression will tell them whether they are concerned about you or they think it is serious or they are not serious. So all these, your facial expressions will be read by the patient. So we have to be careful about these things. A smile is reassuring, while a concerned look shows that the patient's worries are taken seriously, for example. The gestures, the hand gestures, they complement the verbal communication. So usually you should not be sitting close. Your hands should be open, and talking with the hands is a very important component of the communication of the doctors. The open posture is standing or sitting with an open posture. Example, not crossing the arms to appear approachable and attentive. If you cross arms, practically it means that you might not be listening or your thoughts are somewhere else. And if you're talking with your arms, practically that means that you are more attentive over there. Leaning forward when listening indicates interest and engagement, or you are hard of hearing and you can ask the patient to speak loudly. The non-verbal communication, empathy and compassion. I'm sorry, I forgot to animate this page. Empathy and compassion shows emotional understanding by recognizing patient's feeling and concern. Example, I understand this is difficult for you. Will give a lot of courage to the patient that yes, you understand their problem, and you will be helping them in that one. Appropriate touch, a gentle touch on the shoulder or the hand can provide comfort, but make sure that you don't go beyond the norms of the community. Be aware of the cultural sensitivities and the personal boundaries. Modulating voice, varying pitch, volume, and pace to maintain interest and convey emotions effectively. Effective use of silence, allowing the pauses in conversation, can give patient time to process information and express their thoughts and feelings. So when you are listening and you pause somewhere, that will give the patient a second chance to come up to give you or share with you some more information with you. The professional appearance convey competence and reliability. The dressing up of the doctors is very important. They should look professional in their attire, and they should look neat and tidy in their attire as well. The environment ensuring comfortable setting is conducive to open communication, such as arranging seats to promote face-to-face interaction and minimizing the distractions. Usually, it is being recommended that you are talking eye to eye to the patient. The written communication skills are crucial as they ensure accurate and clear documentation, essential for high-quality patient care and coordinating among healthcare teams and professional development. Okay, so the medical documents which we are concerned with are the patient records. Keep detailed, accurate, and up-to-date patient records, including medical history, the examination finding, the diagnosis, and the treatment plans. And the progress notes should be equally well-written and understandable. Write clear and concise progress notes to track the patient's condition over time and communicate with other healthcare providers. Usually the progress notes are handwritten, so there comes the problem of the doctor's handwriting, nobody understands. So we have to make sure that while we are writing the progress notes, our handwriting should be legible. Prescription writing, legibility is important, ensuring that the handwriting is legible, or you use the electronic prescription system. In most of the good medical hospitals, the electronic system is available in which you can send the prescription through the computer networks. The clarity, providing clear instructions for medication dosage, frequency, and administration route. And there is a Google search app for reading the illegible prescriptions, which is available. I think it is free for use. Okay, the written communication also includes the referral letters. They should have a structured format, which will include the patient's detail, the medical history, current condition, and reason for the referral. And the relevant information should include all pertinent information to ensure that the receiving healthcare provider has the comprehensive understanding of the patient's situation. This will reduce the time spent by the second stage medical caretakers in taking the detailed history again and again. So if the referral letter has the important gist of information provided, they can start their treatment much quickly. Discharge summaries should be comprehensive summaries. Prepare the detailed discharge summaries that outline the patient's hospital stay, the treatment received, and the follow-up care instructions. Provide clear instructions for post-discharge care, including medications, follow-up appointments, and any necessary lifestyle changes. And they should be hammered to the students, to the patients, because these lifestyle changes generally are taken very lightly, but in many conditions, they are very, very important to increase the life expectancy of that person. The patient education materials are generally at a display in most of the clinics and the hospitals. They should have a simplified language with the material for which the patient use simple language and avoid medical jargons in that, and the engaging content using diagrams, illustration, and the bullet points are eye-catching, and they should be displayed at the appropriate places in the hospital or in the clinics. The electronic communication, email etiquettes, write professional emails to colleagues, patients, and their other stakeholders, ensuring clarity and politeness. There are a specific way of writing the emails. Normally, when we write the emails to at a professional level, it is different. When it's a personal level, it is different, because over here we are writing it at a professional level. So there should be a subject line over there. Used at level of formality, dear, please, thank you, regards, sincerely. All these words are very helpful and very encouraging to the receiver that who is going to take care of the condition. Keep content brief and to the point, and proofread every email before sending. It is very important that you should read the email which you have written before you send to the. Sometimes we send the half of the emails when we are in a hurry, and later on we regret that the very important information has been missed in the message. Write mails before entering the recipient email address. That is again one way of avoiding that you send a message half cooked. Double check that the recipient is correct. Ensure to CC all relevant recipients. Don't always have to reply all of the people concerned, but all the concerned people, all the relevant recipients should get that email. Signature block, your full name, your title, the name of the hospital, company, etc., and the contact number should be given. Electronic health records are used to document patient information and communicate with the healthcare provider. Unfortunately, what is happening is that there are 8 working hours for each doctor. 5.8 of those 8 working hours are spent in keeping those electronic healthcare records. Interestingly, the most of those time taken is by the infectious diseases, in which 8.4 hours are spent. So how can we spend the 8.4 hours if we have 8 hours working hours? That means that the doctors are working overtime after working hours to complete those electronic health records. The number 1 is the infectious disease. Number 2 is endocrinology, 7.7 hours. Nephrology, 7.5 hours. Primary care, family and internal medicine, 7.3 hours. And hematology, 7.2 hours. That means that most of the medically related specialties, the medical specialties spend more time in keeping those records, while the least records are kept by the anesthesiologists, 2.5, orthopedics, 3.3, otorhinolaryngology, 4, surgery, 4, and dermatology, 4.3. And the surgical components, except for the dermatology, probably are using less time in keeping those records. This is being a burden on the staff, on the doctors, and generally there is a good debate going on in the UK and other countries that how we can reduce this electronic health record burden of the doctors, because much of their productive time is spent in writing those records. Excuse me. The research activity is again a very important component of the doctors. They have to do their research for the promotions and gain recognition in their institute. Grant writing, write strong grant proposals to secure funding, clearly explain the research goals, methods, and potential impact of that. I'm not going to go into these details. Probably the people who do the research activity are more familiar with all these and they know more about it. The interpersonal communication, build a strong relation with the participants, obtain informed consent, clearly explain research procedures. Scientific writing should be clear and well organized. The data visuals should develop relevant charts, graphs, and tables which help in the understanding of the written content. The peer review give and receive feedback to improve the quality. The presentation skills should be of quality, because sometimes you have written something very good, but the presentation skills are such that they are lost in the conferences, seminars, or in the poster presentations. The teamwork develop create clear communication skills and conflict resolution methodologies. Networking build linked with other researchers and participants, and ethical communication ensure ethics, honesty, and transparency in research communication, and respect the confidentiality. The legal documentation informed consent forms, preparing clear and comprehensive consent forms that outline the risks, the benefits, and the alternatives of medical procedures, and the incident reports accurately documenting any adverse events or incidents to ensure proper follow-up and accountability. These things are come once in a while, but when they come, they are very, very important, and they can be very dangerous if they are taken lightly. So it's very important that we are aware of these procedures and processes, and the appropriate concerned people are doing all this documentation, not everyone. Reflective writing, self-assessment, engaging in reflective writing to evaluate personal experiences, challenges, and growth in the medical field is very reassuring for the people who do this, because later on they will see how they have grown and how they have overcome those challenges in their life. Continuous improvement, using reflective writing to identify areas for improvement and develop action plans for professional development. Confidentiality, privacy, ensure all written communication respects patients' confidentiality and complies with legal and ethical standards. I am continuously highlighting these points because these are very, very important, and because the doctors are in a very precarious condition in which they are responsible for the life of a person after God, so they have to take very good care of the patients. Interpersonal communication should be in a professional way. So I've included the word professional over there. So it's a professional interpersonal communication. Professionalism in interpersonal communication fosters trust and collaboration in a positive healthcare environment. Empathy and compassion, active listening, emotional support, show empathy by acknowledging and validating patients' feeling and concerns, using body language, facial expression, eye contact, and gestures. We have done that in the previous slides. Phrases like I understand, I can feel, I'm sure, help in trust building. Structured information provide comfort and reassurance by listening patiently, offering help, directing in an organized manner, highlighting the most critical points first. Courtesy, use polite and respectful language, regardless the situation and the person can be the person you are communicating with. Respect and support, show respect for the expertise and contribution of the colleagues. Offer them support and assistance when needed also. So it's a reciprocal thing, give and take sort of a situation. Today they are helping you, tomorrow you can help them. Honesty and integrity, personal connection, establish a connection with patient by showing genuine interest in their well-being. Small talk and remembering personal details help to build rapport with the patients. The doctors who, for example, remember the name of the patient when the patient comes in the clinic are very much liked by the patients, and they want to go to that doctor because they think that he or she still remembers them after so many days and after seeing so many other patients. Truthful communication, provide accurate and honest information according to medical ethics, even when the news is difficult, to establish trust and credibility with patient and colleagues. Ethical behavior, uphold ethical standards in all interaction, ensuring that the patient's confidentiality and privacy are maintained. Reliability and accountability, this is the another very important components of the professionalism. Timeliness, be punctual and respect other people's time by being ready for appointments and meetings. Responsibility, take responsibility of your action, admit mistakes. It is very important to admit mistakes as soon as you realize something has been done wrong. When they occur, work to rectify them properly. Professional boundaries, maintain appropriate professional boundaries with patient to ensure respectful and therapeutic relationship. Effective teamwork, verbal communication, speak clearly and concisely, language that can be easily understood, avoid medical jargons. Team building, communicate effectively with team members to coordinate patient care, share information clearly and promptly, avoiding misunderstanding. To ensure a collaborative working environment, give and take constructive feedback. Conflict resolution is a tricky part because normally when number of professionals are working together, there is a chance of having a conflict occurring over there. So mediation skills, use mediation skill to resolve conflict by seeking to understand all perspective and finding a mutually acceptable solution. Avoid conflict of interest, be mindful of potential conflicts of interest, and avoid situations that can compromise professionalism. Address the concerns, listen to the concern, and address them promptly and respectfully to build the stronger relationship. Confidentiality, you have to maintain the privacy of the patient in all levels. Ensure the communication, secure the communication, use secure methods to transmit patient information to protect the privacy, especially if you are writing the letters or sending the patient from one center to another center. Continuous improvement, continuously improve your interpersonal communication skills through training, practice, and self-reflection. Documentation, ensure accurate and thorough documentation in medical records and other written communications. The cultural competence, awareness, and respect for the cultural differences that we have done, and inclusivity is ensure that all are being valued and understood regardless of their cultural background. And this is very, very important if we are in a country which has multicultural, multi-ethnic, multi-religious sort of a setup. Patient education, process of influencing the patient behavior and producing change in knowledge, attitude, and skill necessary to maintain or improve the health. Health literacy is important. Explain complex medical information about the condition and diagnosis in simple language. Use visual aid and examples to enhance the skill of self-management. Especially if you are telling them how to use the medication or the gadgets at home, you have to make the patients literate about how they can be used and what are the bad effects if they are not appropriately used. Motivational interviewing, encourage patients to share their thoughts and feelings to foster a collaborative approach. Informed decision, explain all the possible options for investigating and treating the condition or a disease with the possible side effects and financial crunch. It is very important that the patient are aware what they are going through and what are their prospect for the future. Support system, explain all the possible support systems, including the social and religious support available for the patients and their best choices to avail. Technical resources, the social media, mobile health apps, tele-health services, AI solutions, all can be informed to the patients to get help to understand their conditions and their prognosis better. Clinical communication skill is the last component, and that is the when part of it. Models of clinical communication, elements of clinical communication, teaching learning methods of clinical communication, and assessment of the clinical communication are the 4 important components we are going to discuss in this part of the presentation. What are the clinical communication skills? The patient expects doctors to be supportive, non-judgmental, empathetic, open, honest about the details of their illness, the choice of the treatment, the side effects of the medication, and the expected relief in symptoms. These are all what the patient expects from you, and this is all the information we have to give to the patients for how long the treatment will be, how much will be the expenses of it, what are the side effects of this thing, how much the relief they are going to get. Be truthful, be honest to the patient. During interpersonal interaction in clinical settings, the doctor display both positive and negative role model behaviors. This has been observed. These unspoken messages form part of the hidden curriculum which influence students' development as physicians. So sometimes we unintentionally are sending wrong messages to the students which are following their favorite clinician. So the responsibility, the onus is on the clinician that his or her approach to the patient should be so picture perfect that the students are going to learn all the good things about the doctor-patient relationship. Effective communication during the medical interview plays an essential role in determining the physician-patient rapport, patient-physician satisfaction, patient's adherence to the treatment plans, and frequently the course of the illness itself. So it's a huge burden that we should have the very straightforward communication with the patients and their relatives concerning the management of the patient. Ineffective communication in medicine is associated with poor health outcomes, doctor shopping, and litigation. So if we are not communicating effectively with the doctors, the patients will suffer with poor health outcomes, and they will go for doctor shopping and might end up suing the facility. Pre-operative visits can more frequently prepare patients than intramuscular sedation. That was the statement given a long time ago in 1963, and this was in regard to the anesthetist, because anesthetists talk very little with the patient, and the patient's perspective was that if they talk with us more politely and inform us, it will be better than giving the intramuscular sedation to us. Clinical, okay. In an observational studies of outpatient visits with general and orthopedic surgeons, the focus of the interaction was on patient education, discussion about the medical condition, explaining the treatment option, and helping the patient to understand the procedure in detail. What the orthopedic people were telling them is how they are going to treat the whole procedure of the surgery, and what they are going to do in that procedure, which is strikingly different from the primary care, that is the medically oriented topics, the specialties where more time is spent on the history taking and physical examination and less on patient education. So this was the report of a study which was done in 1999. Patient described as monitors seek information about the risk. There are some patients who will ask, what will be the side effect of this medication? What will happen to me after this surgery? What are the risks which we are taking? Whereas blunters are those who tend to avoid this information. They want to keep their eyes closed, their what they say, their beaks in the sand. They keep they act ignorant about it because they don't want to. They don't are capable of taking all that information. So anxiety occurs in monitors for lack of information, and in blunters for too much of information, was one of the findings in a paper. Anxiety is affected by the patient's satisfaction with how appropriately information is delivered, and not with how much information is transmitted. If you give concerned, short, sweet, information to the students or to the patient, that will be more informative to them than you give a huge lecture or huge information, which is of no use to them. Some of the common barriers of good communication include use of medical jargon, inability to communicate in a simple language, arrogance behavior of the information giver, lack of enough time dedicated to the doctor-patient encounter, and frequent interruption while the patient is narrating his problem. So we have to be very, very aware of these problems and try to tackle these at our level so that the patient satisfaction is increased. The models of clinical communication, the one model is called as the Bayer Institute of Healthcare Communication E4 model, which was introduced in 1994. It emphasizes on 4 E's: engage, empathize, educate, and enlist the patient. Engage by active communication, empathize and understand and show empathy, educate, provide necessary information, and enlist, make them partner in their own care. The 3 functional model of 2020 is on data gathering, emotion, and education and motivation. Actively listening, open and closed-ending questions, simple language. The emotion developed understanding and respond to patient's emotion. And education and motivation change should bring a change in behavior. The Calgary-Cambridge Observation Guide of 1996 step-by-step tells about the history taking, actually initiate the session, establish some understanding with the patient, greet, introduce, show respect, identify the reason for consultation, listen, identify the problems, gather the information, background histories, perspective of illness, the physical examination, then explain the plan of the treatment to them, and the session closing in which you summarize what has been said, the safety of the patient, and the final check that everything has been understood and the patients are satisfied. The patient-centered clinical method of 1996 is the assessment of patients' holistic experience with the healthcare. The concept of the disease and illness with an understanding of the whole person will be discussed. Finding common grounds with the patient, maintaining a focus on health promotion and disease prevention, emphasizing the significance of patient healthcare practitioner relationship, and being realistic. This is the newer approach in which the medicine is done which is patient-centered, and everything is being informed to the patient about the facilities available, the methods available, and they're given the chance to select the best from them. Then is the SAGE framework of 2001, in which you set the stage, elicit the information, then you give the information, understand the patient's perspective, and then end the encounter. If suggesting a new or modified treatment prevention plan to them. Okay. Now, this is the latest and the most important elements of clinical communication is Kalamazoo consensus statement, which identifies 7 essential elements of physician-patient communication during the Fetzer Conference on Physician-Patient Communication in Medical Education, which was conducted. Kalamazoo is in Michigan. Initially, we thought that it is in somewhere in Africa. No, but it is in Michigan. The element 1 is to build a doctor-patient relationship. Element 2 is open the discussion. Element 3 is gather information. You will see that this is all the level of steps which you take in history taking, and all of them should be there while discussing the medical condition of the patient. Understand the patient's perspective, share the information. Element 6 is reach agreement on problem and the plans. And element 7 is provide a closure. So it's a whole plan of how the patient will be treated, what are the stages, how much time will be required, what are the future planning for that. This all is discussed in this setup. So the first is element 1 is build doctor-patient relationship. Establishing trust and understanding with patients is the foundation of effective communication and ensures that patients feel comfortable and confident in their care. Active listening, empathy, respect, open communication, consistency, be reliable and follow up on the previous decisions. Non-verbal cues, use eye contact, nodding, and open body language, show attentiveness, and personal connection, show interest to the patient's life beyond their medical condition will help in building that doctor-patient relationship. Element 2 is being open to discussion, starting the conversation without interruption as key to a good doctor-patient interaction. Greet the patient warmly and ask how they are doing. Don't hurry, let the patient complete the opening statement. Set the tone by explaining what the visit will cover. Encourage the patient to share their main concerns first. Avoid interrupting the patient while they speak. Allow them to fully express. Establish and maintain a personal connection. Is 2. The third element is to gather information. Now it's your turn to ask the questions. So questions can be open-ended and closed-ended, used appropriately. Structure, clarify, and summarize the information with the patient. Keep on telling them, this is what you have understood. This is what you are saying, so that you know that what you have understood is exactly what the patient is saying. Actively listen using non-verbal example, eye contact, and verbal example, word of encouragement techniques. The element number 4 is to understand patient's perspective, explore the patient's circumstances, beliefs, concerns, and expectations, their family background, their culture, their gender, age, socioeconomic status, and spirituality is again a very, very important factor which we should be concerned about. Explore the beliefs, anxieties, and expectation about health and illness, especially if there is another person who is sick in the family. The anxiety level will be increased, and the patient might come up with the beliefs that probably he's or she is very, very sick. Acknowledge and respond to the patient ideas, feelings, and values. The element 5 is to share the information, provide clear and understandable information to the patient, use language that patient can understand, check for understanding that what you have said, I have understood in the same way, and encourage questions and clarification. Excuse me. Element 6 is agreement on problems and plans. So you tell them that this is what you think is the problem and how you plan to go about it. Collaboratively deciding on the issue and treatment plans. Encourage the patient to participate in decisions to an extent he or she desires. Check the patient's willingness and ability to follow the plan. Identify and enlist the resources and the support. And lastly, the closure, summarize discussions, ensure the patient's questions are addressed, ask whether the patient has any other issue or concern, summarize and affirm the agreement, and discuss the follow-up, example, next visit or plan for unexpected outcomes. The teaching learning methods of the clinical skills. To learn communication skills, the student should be given detailed written guidelines, opportunity to practice, chance to be observed, and feedback by the experienced facilitator with an aid of audio or videotape. This has been recommended by a number of papers which have been published recently, that these are the information which should be given to the learner while they're communicating with the patients. All facilitator and doctors who are observed by learner or colleagues are modeling. So their skills, their behavior, and their attitudes should be at par to the standard, so that the students who are following them should learn the good habits. Although there are some improvement after the lecture series, the most significant gain in history taking skills were obtained following a small group skills workshops. So practically, if you want the students to learn how to take a history, it's better done in a workshop format than in the lecture format. Didactic method followed by observation, feedback, and video or audio recording of performance are required for effective improvement in the learner skills. Usually this type of interactions, starting from the problem-based learning, some of the sessions are videotaped, and they are shown again to the students to tell how they're performing. Experiential learning, systematic delineation and definition of essential skills set by accreditation bodies and university program outcomes. Medical schools faculty and faculty's detailed projection of the learning outcomes will guide the students. Observation of the learners while interviewing either real or the simulated patients and while performing a procedure step by step. Well-intended, detailed, and descriptive feedback should be given, non-judgmental yet constructive. Follow up on feedback and monitor the progress. Video or audio recording and the review of it will tell the students their strengths and weaknesses and how to improve. Repeated practices and rehearsal of the skills with facilitator feedback will practically will affirm that the skills they are learning are at par to the best one. Active small group or one-to-one learning allow each learner frequent opportunities for practice, participation, and individualized coaching, and provide the perfect forum for developing strong skills of collaboration and collegial communication. It is very important that the small group meetings are done, activities are done with the students to learn those skills in which a number of people are involved. Experiential learning by doing can be highly effective for teaching communication skills. Role-playing is one of them. Create scenarios for verbal and non-verbal communication. Group discussion and debates to articulate their thoughts clearly and to listen to others. The storytelling, students can create and share stories to improve their ability to convey a message. The peer feedback, the students telling about their colleagues, which is a constructive feedback sincerely and effectively is helpful. Real world application is communication to various settings for practical experience and confidence. Simulations and games, mock interviews, crisis management situations, or online simulations help to teach communication skills and can be fun as well. Reflecting and journaling, students can have their writing journals, so-called portfolios or reflections, are studying to reflect on their experience and jot down what they have learned. They can help them become more mindful and intentional about their communication. Problem-based practices. Problem-based learning is an effective way to teach communication skills as it places students in the real-life scenario. Case studies are important in that respect. Students with a relevant real-life case study analyze the situation, identify the problem, and propose solutions and communicate their findings. This is in a closed settings in which they are working among the students group, so they are more open in discussion. The group projects also involves researching a problem or developing a comprehensive solution. Students will practice teamwork and collaboration over there. Role-playing simulations create scenarios where students must negotiate and mediate conflicts in a conflict situation. This improves their ability to communicate under pressure and develop empathy. The problem-solving workshops can be conducted where students are given complex problems to solve in group. This hones their skills in articulating ideas, listening, and providing the feedback. Reflection papers. After completing a problem-based task, students write a reflective paper on their communication strategies, in which they assess what they have done and what are their shortcomings and how they are overcome these shortcomings. Presentation challenges, as the students can make public speaking of a problem and present information clearly and effectively. Peer review sessions include peer review component where students critique each other's solution of problems. Students will learn to give and receive constructive feedback. Real world problems include actual problems faced by doctors. Students work to propose real solutions. This gives students practical experience and build their confidence in professional communication. Open discussion forums with students to discuss their perception and progress in interpersonal communication skills while working as a team is another way of overall understanding the level of the students' communication skills so far. Didactic method in practice is interactive lectures where they provide fundamental knowledge and theoretical framework of good communication. Peer tutoring the students, teaching the other students enhance understanding and promote reflective learning. It is good for the student who is giving the information as well as those students who are learning from that student. So it's a win-win situation for both. Workshops and seminars focus on specific communication skills, such as handling difficult patients, provide targeted learning and practical strategies. Simulated patient interactions, patient scenarios with simulated patients or peers to develop discussion skill in controlled environment. Usually they are done in clinical skills labs. Video demonstration, watching recorded clinical interaction allows students to observe and learn from both good and bad communication practices. Role playing by the students in different clinical scenarios such as doctor-patient interactions help students practice empathy, active listening, and effective questioning technique. Small group discussion again encourage peer learning. That can be done by the students themselves, and the facilitator might not be required for that. The reflective writing, the students should be writing their portfolios that promote self-awareness and continuous improvement. Digital learning tools, online modules, the virtual patients and other digital resources are available, and that allows students to learn at their own pace. Just-in-time teaching is one method of teaching in which the information is given and it is being applied immediately after that, so that we know that how much information the student have learned during the time of the teaching. So that is one way of teaching the students. The feedback, instructor provides constructive feedback on students' communication, and that will help them in improving their communication. Communication skills, attitude scales are available in which you can do a survey of the students and involve all the students, and that can come up with the conclusions. Interprofessional communication skills for medical school students are vital for effective teamwork and patient care in the healthcare setting. IPEs in which medical, nursing, pharmacy students learn together. Interprofessional education is a very much in thing nowadays, and many of the medical schools in Malaysia, they have sessions on interprofessional education and workshops on these activities as well. Simulated team-based learning, IP teams use simulation to practice collaborative care. Collaborative projects can be done in which group projects by the IP team workers, team members from different specialities, they are involved. Case conferences and debriefing also, interprofessional team discuss the patient cases together and they learn from each other. The communication skills workshops focused on communication strategies of different specialities and different categories of the staffs. The role-playing exercises students take on the role of different healthcare professionals to appreciate, and they do create videos of these things, and these videos really reflect what they perceive the role of the doctor is, or the nurses, or the ward boys, the different people in the wards and in the medical setting. Other is mentoring and shadowing, reflective practice, feedback from interprofessional peers, cultural competence training, ethical professional courses. They all help in developing the interprofessional communication skills. The assessment of the communication skills among medical students is crucial, ensuring that they are well prepared for patient interactions. Objective structured clinical examination is the most commonly used method in which the students interact with the standardized situation and evaluated using structured checklist or the rating scales. Mini CX is the truncated way form of the observed long case examination, in which only a small component of the long case is being observed. Direct observation, faculty member or trained observer assesses the student during real patient encounter. Self-assessment and peer feedback is usually done in the closed environment, where the students reflect on their own communication skill and receive feedback from peers. Communication skills attitude questionnaire again is also available, in which you can assess the attitude of the students towards their training. Standardized patient feedback can be taken, in which simulated patients provide feedback on the patient's communication skills. Written examination, written test to assess the student's knowledge of the communication principles is also applicable, especially in the early years of the medical school, year 1 and year 2, when they're just learning those skills. Reflective journal again is important for the assessment of the students in the early phase. Case conferences, when the presentations are done in the hospitals and the cases are discussed, the students can discuss the patient cases and the strategies with the peers. Role-playing exercises, student practice and refine their skills with peers or standardized patients. 360-degree evaluation, when you get the feedback from the multiple sources, including patient, peer, faculty. And self-assessment provides a broad overview of the patient's communication abilities. Others are supervisor reports and the portfolios, etc. Okay, so this is some of the assessment questionnaires which I have collected for you. One is on the neonatal intensive care unit parent experience survey. The second one is the Faculty of Medicine, University of Malaya PBL session student evaluation form. Third is students' perception of lecture in communication skills. So normally these type of questionnaires are filled by the students, and we assess how the students are taking these different teaching learning methods and how effective they are. The communication skill competency, according to the Kalamazoo checklist, is also being done, in which the same wordings are used, which are highlighted in the Kalamazoo checklist, and we see that how competent the students are in each and every component of it. The survey to evaluate self-assessed physician-patient communication skill. Again, this is a survey form which I have put over there. This is for your information and for your interest. If you want to do any survey of these things, it will be helpful. So in closing, the process of inculcating good communication skill requires a framework of interpersonal and communication skills, development and implementation of a uniform model for the assessment of these skills. Consensus is needed to build a uniform framework of communication competencies by working with program managers, course leaders, examination directors, simulated patients to both teach and assess communication skills. That is during when we are either developing the curriculum or we are looking through the curriculum to modify the curriculum at some later stages. Communication skills are woven into the broader medical curriculum in all disciplines and emphasizing their importance in patient care. So the medicine faculties and the surgical faculties all have their own methods of communicating with the patients and with the other staff members. Faculty needs to be trained in implementation of the modules in which the communication skills are being inculcated. Frequent, regular feedback should be provided to the students to improve their skills. A good communication skill training program should be multi-session, multidisciplinary, using multiple methods and have opportunities for demonstration, discussion, reflection, practice, and feedback. Normally these type of training programs are done once in a year for each year of the medical learning, year 1, year 2, according to the level of the students and how much they should be knowing at that level. So that keeps on polishing their skills over time. Thank you very much.
Yes, thank you very much for your patience and attending the session. Now it's open for questioning. We have some questions in the chat, and we start with Dr. Yogesh. Dr. Yogesh, would you like to present your question yourself, or should I read it for you?
You can read, sir.
Yes, you have two very interesting questions. Can you share with everybody, please, Dr. Yogesh? Yeah, unmute yourself.
The question was how much
A
communication
bit loud,
can,
please. Increase your volume.
how much communication can be taught and how much communication has to be learned by observation? That was my first question.
Yeah, let's address that. I think it's very interesting that how much communication should be taught and how much should be learned through observation. Can we open this question to the floor and see what people think about it? How much communication should be taught and how much should be learned through observation? That's the question. Any opinions on this? Maybe we should get Dr. Yogesh opinion first. What do you think yourself, Dr. Yogesh?
Sir, I think most of us learn by observing, because theoretically you can talk a lot of things, like today's lecture was a lot of theory of communication, but practically there are different, like every batch has 100 students, 100 personalities, and they have different levels of communication. How much they like again, the component in communication is what you are talking and what is understood. That also makes a lot of difference. So finally, the student has to realize communication is the crux of everything. And most of the problem is in the medical field is happening because we are not communicating properly to the patients. The relatives also are involved in this. And like sometimes we are trying to communicate, but the patients and relatives are not understanding. So there are a lot of components involved.
Yes, I think, Dr. Yogesh, I fully agree with you because this is a skill which is learned through practice and through practical and with little bit of theory. So theory should provide the basic rules and regulations that, for example, how should you behave, how should you start communicating, but most of the things, and actually the practical things you very rightly said, would be learned through observation and the practical skills. Yeah, Dr. Aisha Abdullah has want to say something on this. Dr. Aisha Abdullah?
Yes, sir. Thank you very much, sir. And the question is also very interesting. But I think the question is not about whether it's how much should be taught and how much should be observed, because whatever is taught, even that is learned through observation. So observation is an essential component of all learning. The question, I think, is about how much of the communication skills can be taught through formal learning and informal learning. So how much of it should be formally taught and how much of it can be left to informal learning. Unfortunately, most of the communication skills learning happens in the informal curriculum, through the hidden curriculum. The impact of the formal curriculum is very less. So what we can do is that we need to be aware of our informal settings of communication and need to be aware of the power of the hidden curriculum in communicating the communication skills to our students, and kind of a multi-dimensional 360-degree evaluation of ourselves, that all the time we are aware that communication skills are being imparted, whether we are conscious of it or we are unconscious of it, the learning is happening. So it's going to be a very creative blend of formal and informal. Most of us teachers are used to planning in the formal content of the curriculum. We are not very much into how to plan for the informal. We need to take that into consideration also.
What I get, Dr. Aisha, is that this is a continuous process. So, for example, if teachers are role models, the students are observing them, and each and every move of them and the way they communicate is being observed. So this means that practically teachers should be very careful, and they should know that students are constantly observing them and learning them from them, different, not only clinical skills, but other skills like communication. Right. The other question which Dr. Yogesh raised was that how to improve communication skills of an introvert student. And another important aspect and practical question, how to improve communication of an introvert student. So anybody want to share your opinions? How to communicate, train or improve the communication skills of a student who is not really communicating openly? Any ideas? Anybody has any experience to share of such students? We all face such students that who are not very communicative. I personally, I feel the first step would be to identify such student, and then to communicate with that student in private first. Maybe we can take the help of their mentors as well and try to understand the reason, because just without understanding the reason and addressing that reason, we may not be able to succeed. Maybe student has a feeling that he is not good at language, or he is not good at finding the right words, or there may be other hesitance. So here, so there somebody just wrote that praise them whenever they make an effort. They should be praised. Any other ideas? Yes.
Can I add?
Yeah, sure, please. Yeah, Dr.
Sir, so my question is from my personal experience. Like, I was supposedly an introvert till school time.
Right.
The day I entered the medical college, I realized by not talking, I cannot survive in this field.
Right.
So the first thing is the student has to realize the introvert nature cannot help in growing.
Right.
So the realization of the student is the primary thing. Then the teachers will take time to realize this is an introvert student.
Right.
But if the student himself or herself realizes that introvert is not the way forward, that is going to help.
So maybe, Dr. Yogesh, the one thing I admire your medical school, they have trained you in this aspect very well. But maybe what I get from your point of view is that this should be something from the very beginning. Let's say the introductory sessions in the medical school should address and inform students that, like, if you are not communicating, you are not asking questions, you are not taking part in the debate, maybe you would not learn. So,
Yes.
I mean, we have
Yes.
to make students realize that this is something which they need to address.
Yes, sir. The self-realization and followed by the institution telling that this is not the way to move forward. And like with the number of student increasing in our setup, sometimes it may not be possible for the faculty to pick up those people. With 150 or 200 students and 100 faculty, it might not be easy to pick up the introvert students.
Can I add? The students who join the medical schools come from different backgrounds. Some students are very confident in their communications because they have been involved in different activities in which the communication was involved and in which they were given the roles to play. For example, they were good debaters over there, or they were good communicators, or they were the class reps, and they were managing the group of students. So they will be more open and they will be more participatory. When we assign the students to the mentors, it is one of the responsibilities of the mentors to take care of those students and know which of the student has which personality type. That we gauge by their contribution and their participation in different teaching learning activities in the classroom. For example, in PBL. PBL is a small group. There are 10 students, so maximum 11 students, and there is a facilitator over there. And I'm sure that facilitator would be able to gauge which student is active and which is not. And that the facilitator, that mentor will be able to, that facilitator will inform the mentors, and that things are discussed in our meetings. So for example, after the results or the curriculum committee meetings, that how the students are performing and which students are lagging. So practically, we need to keep a track of the students who are lagging behind only because they are shy and they are not able to communicate. It's not that they don't know how to communicate. In the private, they are very talkative and they can talk very good and very they are very articulate about it. It's only when it comes to a group, then they are lagging behind. So the mentors should be the one who should be recognizing them, and they should be helping those students to open up in the communication. This is one way.
Right. Thank you, Dr. Rukhsana. Dr. Aisha Abdullah, please unmute yourself.
Sir, again, a very good, interesting question. MashaAllah. Very good questions, very good quality, and makes you think. So one thing I want to say here is that being an introvert is never considered a barrier in communication skills. This is an approach towards communication which is different than extroverts. So even if somebody classifies as an introvert or extrovert, students and teachers need to understand that they've got their different style of communication and it's not a barrier. The thing is that the skill set that is required for communication skills in our profession is a very expanded one. And we have 5 years, at least 5-6 years, to expand the skill set of our students. And we can do that through an incremental approach. If somebody has got a different style of communication, but the job description requires a different kind of communication, so that gap can be reduced through teaching and training and practice, starting with low risk, low stakes environments like in co-curricular activities, grouping them students in a comfortable situation where they can comfortably learn from their peers various styles and how to communicate, in people with different situations, and the training of the teachers in providing feedback to students with where there's a gap between what is required as a communication skill and what the students need to have. So my own experience is starting with co-curricular activities, then putting them in formal situations and in small group teaching and learning sessions.
Yeah, I agree with Dr. Aisha. We have enough time, 5 years. So at the end of 5 years, we cannot blame students. If the student is still having that problem, that means that we have not done our job. So, I mean, with that much long period, we should be able to inculcate such important skills. Now, there is an
May I say something, please?
yeah, please, Dr. Vasudev.
I am speaking from Karachi, Pakistan. I am the Vice Dean of a medical college, and I had when I was teaching, a certain group of students. I found that girls, especially, are very shy to come in front of the class and speak up. And the main thing that they feel is that if they say something and the whole class laughs at them, then it is their confidence is going to be shattered. So before what I did was that I told the whole class that nobody is going to laugh at anybody, even if they make a mistake or they say something or slur. So that was a standing order to the whole class that nobody could laugh at anybody or make fun of them. Once the students or the girls knew that nobody is going to make fun of them, they would come in forward. And when they came forward and started talking, sometimes they would stop or they would feel hesitant to say. I said, don't worry, I am standing with you. Take your time and say whatever you want and be confident about it. So each and every student that was shy or hesitant or afraid to come in front of the class, I encouraged them, motivated them, and they knew that I was standing behind them, and they were able to talk aloud and for the first time and remove their shyness and hesitancy, and their introvertness was removed. Once a teacher is standing there and making sure that nobody is going to humiliate or degrade or make fun of them, then the confidence starts building up of these students. Thank you.
Yeah, I think that's very interesting and important concept. In the effort on part of Dr. Vasi. In relation to that, there is a question in the chat box that the common problem, how can we manage a workplace gender inequalities, even though when in front of you, when your manager or boss treat differently? So that's and how to overcome that discouragement and demotivation. So I think in that situation is we need to actually train the faculty, train the teachers and train the faculty. That is the only answer. The other I can think of is that maybe a couple of students can meet that teacher in private and express their concern. But I would like to get opinions from the floor. Anybody? Have you faced this situation when the teacher or boss himself is discriminating between different genders in terms of this communication?
May I be the first one to talk about it? Because I see that when there is injustice being done, then this matter should be reported very diplomatically to the higher authorities, and they should be involved in telling that person that what he should not do. And I think, if you talk directly to that person, he will become your enemy. So it is better to go to the administration or the higher authorities and tell them that this is a certain problem that they should look into it and they should solve it. And also tell them not to identify me or that person who is reporting this matter.
Right. Okay, now there's a supplementary question in this by Dr. Anam Tahir, that how to train faculty any ideas how to train faculty in teaching communication skills?
As Madam Ruxana said, that you need a workshop for that, and people should be encouraged to join that workshop, and that workshop should be conducted by somebody who really knows how to teach and train the faculty and staff. And these workshops sometimes are very interesting, and a lot of people want to sign up for it, and they really help a lot in to the faculty in the teaching methodology.
Yeah, somebody was suggesting in our WhatsApp group that one way could be to invite the people who are expert in this linguistics and take their help. And it can be sort of generic as well as a professional approach to that. So yes, the workshops are the sessions where real experts are helping to learn or to train the teachers how to handle these issues. Yeah, Dr. Aisha Abdullah, please.
Sorry to raise my hand again and again, but sir, the questions are so engaging.
Right.
The first one, sir, I would like to respond to that one, that gender inequality and gender related issues. Unfortunately, yes, it's there. It's very much there, and it needs a lot of education on the part of the teacher and training to get rid of these issues. How we deal with it is that if the feedback system of an institution is working really well, the students do give feedback if there are any kind of gender discriminatory communication going on, and the concerned teachers are then counseled through a system. As regards the training of teachers in education, then 1 or 2 workshops, even by an expert, does not help. It needs to have a programmatic approach where each new teacher that is inducted has to go through a set of courses, not workshops, but courses, so that it's an ongoing process. It's a long process. Acquiring communication skills is a challenge, and it is a long process. So it has to be done through a programmatic through a point of view, and addressing different aspects of communications like teaching and learning, communication and assessments, written communications, electronic, digital, social, all kinds, and having to have a program every year offering some of the courses and enrolling faculty into that and evaluating that as well.
Yeah, thank you, Dr. Aisha. Let's see, Dr. Anam Tahir want to share her views. Yes, Dr. Anam.
Yes, Assalamu alaikum.
Walaikum assalam.
Thank you so much for such an informative and much needed session. So the point I want to make here is that instead of inviting expert who is non-medical but is expert in communication skills, maybe that person does not have that context in which how we deal our students in the small group discussions in all our context. So what if few of our teachers or medical educationists go and take the training and then come train our teachers, so that everyone in the institute know the basic communication skills and how we want our hidden curriculum to then be shown and have the effect.
Thank you. Point well taken. So there's another, yeah, it doesn't say a name, it says iPhone. Please unmute yourself and
Sir, assalamu alaikum.
Walaikum
It is me, Professor Ahmed Mushwani from Peshawar. I am using the new iPhone, so the name is not written. I just want to respond to a couple of questions. Number one is the gender disparity. The interesting thing is, as you know, in our part of the country, most of the boys may come from the far-flung villages. So the boys are more shy as compared to the girls who are generally from the English medium colleges and schools and from the upper group of society. So the girls are less shy as compared to most of the boys. The girls are more confident. The other point is about this communication. from the discussion, I have got an impression that most of the people think that communication is just talking, whereas best communication is not the talking part of the communication. The best part is the active listening. Whosoever is a good listener is a good communicator. The other was one important point regarding the communication. When we are communicating from face to face, the most important thing is when we are facing each other, and if we look to the person to whom we are talking, only then he or she feels that we are addressing that person. But the problem is not only with the girls, even with the boys. Some of the boys complain that whenever we face a girl and we look in the face of the girl, so we become shy. So one of the presenter taught us a trick or a secret how to face this. He said that if you are facing a person from the opposite gender, instead of looking in the eyes of the person who are facing you, if you look at the bridge of the nose, you are facing the person, but that part of shyness which happens when someone looks in the eyes of the person, that disappears. So that is the third point. So
we got a good tip. Yeah.
This is very important because I have asked many of students and I have practiced it. Whenever they face each other, first they are shy, but when they look in at the bridge of the nose, then they feel, yes, sir, that thing has disappeared. So this is very important. And regarding this teaching of this communication skill, as we know, from this present presentation, there are different types of communication, different scenarios, different contexts. It is not only talking. It is the written, the verbal, all sorts of communication. So this, as I have shared in the chat, this is one of the most important presentation. And as you have suggested, for the teachers, this workshop from someone who is expert in communication and linguistics, that definitely helps the faculty, and the faculties can only teach the students if they are themselves trained. And the other thing is this small group and this mentoring is very important tool for teaching this communication. In small groups, if the teacher rotates the different roles and different groups of the small groups and give opportunity to every student, those who are shy or those who are very talkative, if they rotate, I think that also helps and improve. And it is, I think, with the passage of time, with experience, I have seen some of the teachers who come and for the first time face the class, they are very shy. But with the passage of time, they become very confident and they learn how to communicate. The two-way communication also improves with the passage of time.
Yeah, thank you very much.
Thank you very much for giving me the opportunity to share my views, sir.
Thank you very much, Prof. Mishwani, for some important views and the tips. Now, what we feel at the end is that communication has so many different facets. It's not.
Sir, I want to say one point, if you allow me.
It's not just talking to somebody, but there are so many other facets which actually contribute to the active session. I hope this session has raised some awareness and has created some interest to look into this field. And before we finish this session, let me share with you one more slide, which we would.
Sir, before you go there, can I say one word?
Sorry?
Can I just say one important aspect? I just want to say congratulations to Ms. Roxana for a very excellent presentation. One thing about communication that she missed out, I just want to point it out. I have done mass communication and masters in it. And one point that should be always said is that verbal communication is only 7% of communication and 93% is non-verbal. It is written in all management books, and I think we should also consider that whenever we are.
No, I think that's important. That's what I mean. You have the exact figures, but what I was trying to say is that communication is way more than simply talking. There are so many other components to that. Now, before we end this session, I have this appeal, and may I propose to each participant to donate $1 or equivalent amount in your local currency to any deserving individual in your neighborhood or any public welfare organization in your community after attending every webinar conducted from this platform. With that, I really thank everybody for your active participation. It's a lot of encouragement for us to continue our work in this field, and we will inshallah see you soon again. I will share the video recording of this session very soon in the groups, inshallah. And with that, thank you very much, and Allah Hafiz.
Thank you very much, Sir Alamsher, and thank you everybody, and good afternoon from Peshawar. Allah Hafiz.